Hi, everyone, and welcome to DAS Health webinar, Unlocking Success, Essential Insights into the MIPS 2024 Final Rule. My name is Lindsay Lanning, and I lead our government incentives team at DAS Health. Now, before I get started, I would like to take a moment just to explain the process for today's presentation. First, I want to mention that this webinar will be recorded. We'll send out a copy of the slides and recording within the next week. Next, for those of you who aren't familiar with DAS Health, we offer a wide range of solutions to support our clients' growth and seamless operations with over 25,000 providers supported and over 30,000 endpoints managed. We are a trusted healthcare IT partner. And you can see, I wasn't joking when I said we offer a wide array of solutions to support your practice. This includes everything from cybersecurity, hosting, managed IT services, consulting. We have revenue cycle management, patient engagement solutions like CCM and RPM, and as you all already know, MIPS reporting assistance. Okay, so back to today's webinar. At the end of the presentation, we're going to open up the floor to questions from you. We will answer all questions at the end of the webinar, but you may type them in the questions area of the webinar control panel whenever they occur to you. And finally, for audio clarity purposes, everyone's phone is going to remain muted throughout the entire webinar. So if you experience any audio issues, please use the chat box to let us know so we can try and help resolve them. And again, questions may be entered in the questions box. So without further delay, I would like to introduce my co-presenters for today, my amazing government incentives consultants, Bridget Peterson and Kimmy Watson. All three of us have been working with MIPS, PCMH, and many other quality reporting programs for years, and we each have our own areas of expertise, either with different programs or EHRs or maybe registries, and we are so excited to help your practice any way we can. Now, again, before we get started, I wanted to give you an idea of what we're going to cover. So first up are announcements, just some quick housekeeping items related to 2023 MIPS and some newly proposed rules. Next, we'll dive right into the final rule overview, including a category breakdown from traditional MIPS reporting perspective, and then the changes we can expect again in each one of those categories. Then we're going to touch on both APM and MVP reporting pathway updates for 2024. And lastly, we're going to end on our best practices for 2023 reporting, keeping in mind we are in the last month of the year already. Okay, so introductions, agendas aside, before we can even start on the 2024 final rule, we couldn't pass up the opportunity to address two announcements for all our fellow MIPS, we'll call them enthusiasts on the line. So the first is in regards to the newly proposed disincentives for information blocking. Now, you might be wondering, why are we crashing a MIPS webinar with information blocking updates? Well, because HHS just proposed to make those two related. So HHS, or the Department of Health and Human Services, is proposing that if an eligible clinician is found to have participated in information blocking, the clinician is not considered a meaningful user of certified EHR technology, and therefore will receive a 0 in the PI category of MIPS, which we know totals 25% of most practices, final MIPS score. So how the program stands now, if a provider, if a practice received a 0 in PI, but had a perfect score in all the other categories, technically they would receive a neutral adjustment. However, earning a perfect score in cost is going to be pretty difficult. And as the program continues, that threshold to avoid a penalty is going to eventually increase to above 75 points. So that disincentive will actually result in an automatic MIPS penalty. Not only that, but HHS clarified in the proposal that if a practice reports as a group and one person in that group is found to be information blocking, that penalty is going to apply to the whole group. So as you can see, here's a quick kind of snapshot, I would say, of current information blocking submissions that are pending investigation. And it's no joke, right? I mean, there are over 800 already submitted, and you can see who's doing the submitting in that graph below, kind of by a breakdown. Patients are leading this by far. Now, keep in mind, unlike the MIPS 2024 changes we're about to talk about, this rule is still proposed. So comments are actually due by January 1st of 2024. There isn't a set date for publication for this final rule. However, industry experts are saying that the federal government is moving more quickly than we tend to see with other laws. So we should expect something soon after. And don't think if you don't report traditional MIPS and you're in a APM or maybe the Medicare Shared Savings Program that you're safe from this disincentive, because HHS covered you as well. So they are proposing that any healthcare provider, OIG, determines again to have committed information blocking, that they may not participate in the Medicare Shared Savings Program for a period of at least a year. They're also proposing to screen ACOs and ACO participants for that determination of information blocking and deny the addition or inclusion of that healthcare provider to an ACO for at least a year. And if the ACO itself is a healthcare provider, CMS is proposing to deny the ACO's application to participate in the Medicare Shared Savings Program for at least a year. So information blocking is no joke. We've been talking about this for what seems like, forever at this point, but really probably 2 to 3 years now. But we are finally seeing the enforcement of it, and it could directly impact your MIPS final score. So don't let all your hard work go to waste with MIPS. Make sure you are not information blocking. Okay, our next announcement. Now, this is one we've shared on previous webinars this year, and it's just a reminder that there is still a COVID-19 hardship available for the 2023 reporting year. Keep in mind, yes, this would allow you to not report in 2023 and not receive a penalty, but it would also allow you to only report 2 categories and exclude from cost for a full score, which is huge. Almost all of our clients took advantage of this approach last year, which is why we yielded such high results. Most of our client base earned a perfect score for a full positive 8.25% increase that they'll see on their Medicare reimbursement starting in 2024. Now, you can apply for this hardship in your QPP, that CMS portal, just as previous years, but don't forget, if you apply for the hardship, any data you submit or is submitted on your behalf will override that reweighting for that performance category, and the category will be scored. Okay. I swear I'm not stalling to get to the final rule content, but we really want to know how you all are currently reporting or have reported. So for 2020 to 2022, did you submit the EUC, which is the hardship, so take the hardship only, or did you submit that hardship and then end up reporting data for a score? Or did you submit all data? You didn't submit the hardship, you never took advantage of it, you've been getting scored on all 4 categories. Or did you not report at all or submit the EUC? Oops, right? So I'm gonna go ahead and launch that poll. I did pick a multiple choice, I should say, or multiple answers. So I know that you might have changed your reporting method over the years. So please select all that apply. We'll give it a second as responses start coming in here. I really hope I don't see any, we didn't report and we didn't utilize the hardship, but we'll go ahead and give everyone just a few more seconds here to go ahead and input your answers. Still seeing some answers pouring in, it's exciting. All right, we're gonna go ahead and close the poll in 3, 2, 1. And we're going to go ahead and share the results. So you should see those coming over on your screen. About 50%, right? Half have actually, submitted the EUC or taken advantage of the hardship. Absolutely understand taking advantage of this while you could. But 2024 is coming and quickly, and you will have to report. We see some doing the EUC plus data. To be honest, I see a lot of our clients in this bucket, based off our hardship explanation. I think you all probably know why. And then we do have 17% at all data. So kudos to you guys, overachievers. But keep in mind, it maybe necessarily wasn't required. You maybe could have gotten a higher score with utilizing the EUC, or hey, if you got 100% with all categories being scored, you might have had to submit less, which is always a win in our book because we've got to start thinking about audits. So that means less documentation required to submit if you're selected for an audit. And I am happy to report 0% for the did not report or did not submit the EUC. that would have yielded a full negative 9% penalty on Medicare Part B claims. That is not what we wanted to see for anyone. Our next and last poll question, now we're just curious, right, to see what you're planning to do for 2023. And I'm interested to see if this would change after our presentation today towards the end here. But looking at what your plans are for 2023, are you going to stay on that track? I only allowed you to pick one, obviously, for this option. Are you planning to submit the hardship and then report data, or just take advantage of the hardship completely? Or are you planning to not use the hardship and submit data on all categories? And again, hoping we definitely don't see a not report or submit hardship. All right, it looks like responses have paused here a little bit. I will go ahead and close the poll in 3, 2, 1, and go ahead and share the results. Still at a high percentage here planning to utilize that hardship. I absolutely understand that. It's been a crazy year, but keep in mind, I'm excited you're here today to go over what's going to change in 2024, because unfortunately we won't have that option and we're going to have to report. So now is the time to prepare, and you're starting off right by joining us today. And then our next highest, the EUC plus reporting data. Probably a similar approach if you've done that in previous years. And then we still have some on here planning to submit all data. And maybe when we go through today, we can see if we can reconsider or, at least help make sure your scores are as high as they possibly can be. All right. Well, thank you all for your candor. We will now, as promised, start with the actual final rule changes for 2024. So let's look at the financials first. At a very high level, right? The rule finalized to actually cut Medicare reimbursement again. So we have a 3.37% fee schedule conversion factor reduction that was finalized. This is in addition to the sequestration that's already in place and the cut from last year's final rule that are already in place. So you can see from that image in the kind of lower right here on your screen, Medicare reimbursement is not keeping up with inflation, and practices are in dire need of additional financial support in order to stay afloat, to keep their doors open with all these Medicare reimbursement cuts. Now, as expected, Congress is receiving a lot of negative feedback on this. This is not something CMS or any of the other agencies have any hand in. This is all pending congressional action. So we will see what, or if there is any future rulemaking to combat this reduction. But you can see why earning a positive payment adjustment under MIPS would be a huge help in future years to offset these dramatic decreases. So what does this mean for you? Again, we've already pretty much hit on this, but MIPS incentives become even more of a priority in order to even the playing field, if you will, and get back to where you were at your previous reimbursement levels, what they were under Medicare before all these cuts. We already know 2022 adjustments were huge, and as long as you performed well, these will offset the current and future cuts. So we know there's a hardship available, but again, this is why we're really encouraging everyone to try and report to earn a positive adjustment. Okay, financials aside, now that I have your attention, let's start with traditional MIPS reporting changes at the program level. And keep in mind, these are final. So first is, I would say, some good news. So say it with me, woohoo. CMS is not changing any of the current eligibility criteria or the category weights. So if you have been eligible in the program each year, chances are this won't change and you will be again in 2024 based on your current Medicare population and billing. So the category weights are staying the same, right? 30% for quality and cost, 25% for PI, and 15% for improvement activities. Now, this has been the weighting since 2022, and it hasn't changed. But here's where things get good. Initially, in the proposed rule, CMS planned to increase the final score to 82 points to avoid a penalty. But CMS did not finalize their proposal to increase the performance threshold from 75 points to 82 points. CMS finalized to maintain the performance threshold at 75 points to avoid a penalty for 2024. Very good news for all of us. Don't worry, you're on mute. If you let a little yes or woohoo slip, you're safe. No one heard you, but we all 100% agree with you. So you may be asking, right? This is my first question. How do they decide the performance threshold? Do they close their eyes and pick a number from 1 to 100? And while, we may feel that way, especially after this change, that's actually not the case. Typically, CMS looks at a previous year's data to set the performance threshold, but for 2024, they were proposing to take it back a few years using the average of the mean final scores from 2017 to 2019 performance years. What's wild is that the category weights were much different at that time of the program. So those final scores, wouldn't be comparing apples to apples for 2024 performance. Not only that, but look at what we've been telling you to do, right? To consider taking the hardship if a COVID-19 exception applies to you for some of those categories, and that would potentially yield a higher score. And CMS had to acknowledge that, specifically that the hardship would result in many clinicians not submitting data for certain, performance categories in order to receive that reweighting to 0%. And this could potentially lead to inflated scores that would not be representative of current scoring policies. So, long story short, they did not go forward with this increase, and ultimately they finalized to use the 2017 performance period and kept the threshold at 75 points. Okay, so now that we really have your attention and you understand how important it is that you earn a high MIPS score financially, I'm going to turn it over to Bridget to take you through, what CMS finalized for the quality category specifically. So Bridget, it is all yours.
Great, thank you, Lindsay. Okay, so let's start by looking at the changes to the quality measures in the 2024 final rule. First, just as there are 198 total quality measures available for 2023, this will stay the same for 2024. However, CMS has finalized significant changes to 59 existing measures. Additionally, they have removed 11 measures while introducing 11 new measures. Also, it is important to mention partial removal measures. This means quality measures are no longer available to report through traditional MIPS and will be moving to MVP reporting only. CMS has finalized this for 3 quality measures, and we will take you through these measures a bit later. Also, it is worth noting that when any measure has changes, whether big or small, this often causes the associated benchmark to have changes as well. So technically, you can still use this measure, but its point value might not hold the same weight as it had in the previous years. Now, on the other end, if you decide to try out a new measure, you will receive a minimum of 7 points and could even get up to 9 or 10 points. And this is to encourage providers to try out these new measures. Now we're going to explore the quality measures that CMS has finalized for removal. Some of the biggest changes for 2024 are measures 112, 113, and 128, which have been retired as both MIPS CQMs and ECQMs, but have been retained for MVP reporting in 2024. If you remember, CMS did the same thing last year with the influenza and pneumococcal measures. So you can no longer report on these individual measures under traditional MIPS, only in an MVP. However, CMS is combining them into a new preventative care and wellness measure, which we will deep dive into on a later slide. Now, I mentioned that CMS removed influenza and pneumococcal measures from traditional MIPS last year and to allow them in MVP reporting only. Well, CMS has officially finalized the removal of these measures for all reporting methods starting in 2024. And this was definitely a surprise, as we assumed they were going to use these as an incentive to join an MVP. And if you're reporting on them for years, we did not expect them to get rid of them completely. However, as I mentioned, the preventative care and care measure and these two will be included in that mega measure, and we will look into these in a few slides. So if you are reporting as an MVP this year, you can still report these two separately. Just remember, this will not be the case for 2024. You will be required to report measure 493, the massive composite measure for MIPS and MVPs. Listed here are a few more measures that are removed, but I specifically wanted to call out measure 402, which is the tobacco screening for adolescents. This measure could be combined with measure 226 or CMS 138, the preventative care and screening for tobacco. But instead of the patient population being at 18, it will include ages 12 and up. Now, they did decide to postpone the removal of the MIPS CQM measure 436, which is the radiation consideration for adult CT and the utilization of dose lowering techniques. This measure will be available for 2024, and they will remove it in 2025 instead. Now let's review the most often used measures and their changes. The first up is the tobacco use. And as I just mentioned, measure 402 is being combined with measure 226, and it will include ages 12 and older. Now, CMS is hoping to get better results with this combination. They're also updating the analytics on this measure. They used to look at the submission criteria that was based on tobacco users with cessation education, but now they will get the final score based on total patients screened for tobacco use. And this will ensure that the correct screening information was collected. And remember, changes to a measure will also change the benchmark or total points given for a measure. It is very important that you are aware of how many points you will be receiving for completing a measure. If you do not know the measure's benchmarks, you could end up with several measures worth very low points, causing you to have a very low score. Now, CMS has stated they will be releasing the 2024 quality benchmarks in late January, so we will definitely be checking on this for these measures. Next is the high-risk meds measure, and they are making changes to the denominator requirements. They have finalized to update the medication table for the MIPS CQM specs in their collection, and this is to match the current guidelines and make sure the measure identifies high-risk medications correctly. Now, they are also suggesting changes to the numerator for all collection types and hoping to make things clearer and capture the right group of patients. Now, for ECQMs, they are making this change by getting rid of certain types of exclusions, and then they will include that information in the numerator criteria. And additionally, they are thinking about medications that might be ordered on the same day, but are meant to start on different days. So they are going to determine how they're going to handle this in the measure logic. Now, the next is controlling high blood pressure. And this will be updated for ECQMs, MIPS CQMs, and Medicare Part B claims measures. This measure has been updated to specify that only blood pressure readings conducted by a clinician or an automated blood pressure monitor or device are acceptable for compliance. Now, this includes in-person readings by a clinician and remote readings transmitted electronically. And you know what that means? Higher MIPS scores for our RPM clients. I know a lot of our MIPS clients also have our CCM and RPM virtual care services deployed, and we have been waiting for this one. RPM reimbursements under CMS requires that at least 16 different days of reading, so our clients should expect a very high score on this measure. Now, our team also runs the CCM RPM division at DAS, so if you have any questions on this, just let us know. Okay, back to quality measures, and here's a brief overview of the new quality measures. Again, it's very important to take a look and see if any of these measures may apply to your practice. Now, it is important to know that new 2024 measures are only reportable as MIPS CQMs and not ECQMs. There weren't any new ECQMs. Second, it may be of value to report on a new measure because, as I mentioned earlier, it's important to pay attention to the benchmark for measures that have significant changes. But it is also equally important to review new measures, see if these would be a good fit for your practice. Because when you report on that new measure, you will receive a minimum of 7 points, whether the measure was scored against the benchmark or not. And there are a number of measures that are topped out or very difficult for you to get 100%. So using a new measure, getting a minimum of 7 points, regardless of how well you do in it, might be a strategy that your practice would like to think about. Now, along with a 1-year delay in removing a measure, a new measure that was finalized in MIPS 2024 is for the excessive radiation dose or inadequate image quality for the diagnostic computed tomography for the CT. This is now being delayed for reporting, and it will not be available in 2024, but will be available in 2025. But as mentioned earlier, the biggest new measure that I want to bring to your attention is the preventative care and wellness measure. This is measure 497, and it is a very interesting measure. This is a new composite measure that combines 7 existing preventative care measures with age and gender-specific screenings and wellness services. The goal is to have one comprehensive approach that aims to provide a well-rounded assessment of preventative care. While each denominator is distinct, they are combined into a single measure. And with this, some of the measures we discussed earlier, such as influenza, colorectal cancer screening, and BMI, can no longer be reported individually through traditional MIPS. Instead, they will be merged into this one gigantic measure. Now let's get into data completeness. Right now, data completeness stands at 70%, which has already been quite difficult to meet. But CMS has finalized the increase to 75%. So what does data completeness mean? Data completeness refers to the volume of performance data reported for the measure's eligible population. So when reporting a quality measure, your submission must identify the total eligible population, or denominator, as outlined in the measure specifications. To meet data completeness criteria, you must then report performance data, performance met, not met, or the denominator exceptions for at least 75% of the total eligible population in 2024. So incomplete reporting of a measure's eligible population or otherwise misrepresenting a clinician or a group's performance, like only submitting favorable performance data, which is commonly referred to as cherry picking, wouldn't be considered true, accurate, or complete and may subject you to an audit. I do want to note that data completeness is specific to Medicare patients for Medicare Part B claim measures only. QCDR measures, MIPS, CQMs, and ECQMs should include all payer data. Accurate or complete, and you just want to make sure that you are including all of your payer data. Now, the measures that don't meet data completeness will earn 0 points unless you are part of a small practice, in which case the measure will earn 3 points. Now, you don't have to worry too much about data completeness. I know it sounds confusing, but if you're using a certified registry or EHR, they will either require you to report on 100% of patients who qualify for the measure, so AKA there's no way to cherry pick, or if it's a registry, here you manually upload the data, and they usually will inform you if you have met that 75% requirement for each measure. Now, this increase will remain consistent until 2026. And after that, it will gradually rise in small steps to about 80% by 2027. Again, CMS is trying to prevent cherry picking data, and they really expect clinicians to report to as close to 100% as possible on all patients. Now, CMS has decided to eliminate the health IT vendor category in 2025 and make it mandatory that the vendor is either a QCDR or planning on going through the self-nomination to become a QCDR. They noticed that the main difference between a health IT vendor and a QCDR was the self-nomination process in the data validation audit. Therefore, they have decided to remove this option and make self-nomination mandatory. Now, if reporting as an MVP, and this includes 7 different specialties, the QCDR is only expected to assist with the measures that relate to the specialty of their clinicians. So for instance, if an MVP includes both surgery and physical therapy measures, and the third party focuses solely on physical therapists, they do not need to support the surgical measures. Now let's review the ICD-10 coding updates. This is something that happens every year when the new codes are released in October. And depending on the changes, CMS would either suppress or truncate measures that were impacted by the code updates. So starting next year, CMS is eliminating the automatic 10% threshold of coding changes that triggers quality measures, truncation, or suppression. They will be assessing the impact of coding changes on a case-by-case and will assess each collection type separately. So as a refresher, here is suppression versus truncation. Now, if a measure is suppressed, it will not be scored by CMS. If a measure is truncated, it will be shortened and will only include the data from January to September before the coding changes. So if you are reporting a suppressed measure, it means that it will not be counted as one of the 6 CQMs you submit. Your quality category denominator will be reduced by 10 points. Out of the other remaining measures you submit, CMS will use your highest score outcome in your high priority measure and 4 of the remaining highest scoring measures. Now, as of this time, CMS has not released any suppressed measures, but they have released their truncated measures, which Lindsay will review towards the end. These measures will only use data from the first 9 months of the year. Okay, now that we've gone through the quality category changes, I am going to pass this along to Kimmy to review the promoting interoperability changes. And Kimmy, it's all yours.
Thanks, Bridget. For this next section, we will be reviewing what's new for the promoting interoperability category in 2024. There are not many changes that will affect what's reported, but let's get into it. For promoting interoperability category, the first significant change and arguably the most monumental and biggest change to the program next year is CMS finalized changing the reporting period from 90 to 180 continuous days. They literally doubled the reporting period. So in the past, certain practices had the ability to select the most favorable 90-day period for their reporting, or would delay until the fourth quarter to ensure all necessary criteria were met before submission. However, starting in 2024, this option will no longer be available. It will be essential for you to maintain consistency in your workflows throughout the entire year. This consistency will provide you with the freedom to choose a period for submission while ensuring compliance with the new requirements. CMS also finalized that the displayed clinicians will no longer have PI automatically reweighted and that they will be continuing the automatic reweighting of the promoting interoperability performance category for clinical social workers and small practices for the 2024 performance year. As for some more specific measure updates, the first is you must attest yes for the SAFER guides in 2024. Now, if you'll recall, this was proposed to be required back in 2023, but CMS gave us another year to attest no without any negative impact to your score. But now, however, next year we will need to complete this. It is the roughly 30-page PDF to complete that is very similar to the security risk analysis. Also, CMS has finalized the modification regarding the PDMP exclusion and made it more difficult. CMS is updating this from being able to exclude if you prescribe less than 100 controlled substances to only be able to exclude if you don't prescribe any controlled substances. We are not shocked by this only because it is state law in the majority of states to require the use of the PDMP and look up patients prior to prescribing. In this table, you'll see the breakdown of scoring for the PI category. You'll notice for the health information exchange measure, you have the option of completing the sending and receiving of referrals or bidirectional or by enabling TEFCA. The scoring pretty much remains consistent for the remaining measures to what we are currently reporting on in 2023. The patient portal measure went down in points and CMS increased the public health reporting options due to the COVID-19 pandemic. In this table, show where points will be redistributed if exclusions are taken for specific measures. For e-prescribing, it'll go to the HIE measures. HIE measure scoring will go to the patient access measure, and then the public health clinical data exchange will also go to patient access if it does qualify. So that wraps up what you can come to expect for the PI category. We'll move on to the changes that are finalized for the improvement activity area now. All right, so here's the breakdown of the finalized changes to the improvement activities for 2024. As you can see, CMS added 5 new activities, removed 3, and modified 1. They did not change the 50% threshold for group reporting required, and they did not add a stipulation in regards to changing activities year or year, which we semi-expected based on the recommendation listed on the improvement activity inventory for 2023. So that's good news. The 5 activities they added focus on more specific specialty activities and, of course, the new MIPS value pathways reporting. And they are improving practice capacity for the HIV prevention services, practice-wide quality improvement in MIPS value pathways, use of computable guidelines and clinical decision support to improve adherence for cervical cancer screening and management guidelines, behavioral mental health and substance use screening and referral for pregnant and postpartum women, and finally, the behavioral mental health and substance use screening and referral for older adults. So CMS has modified some activities. The CMS has finalized the modified description and validation criteria for the use, decision support, and standardized treatment protocols to manage workflow in the team to meet patients' needs activity. This change is designed to explicitly promote the use of CDS, particularly open source, freely available, interoperable CDS, and this is consistent with CMS's goals of moving the needle in quotation marks, to make progress toward interoperability and are not intended to de-emphasize the importance of behavioral and mental health care. There are also 3 finalized removals for 2024, and the one that's of most note is the AUC, or appropriate use criteria activity. CMS is not continuing forward with this program, so they're removing it for credit under the improvement activity. And then we finalized the indefinite postponement of AUC, and they have paused efforts to implement that. So that's why it has been removed as an improvement activity. And now I will turn it back over to Bridget for the cost category.
Thanks, Kimmy. Okay, so let's look at the cost measure updates. So the cost performance category accounts for 30% of physicians' MIPS final scores. CMS has added 5 new episode-based cost measures with a 20 episode case minimum. So to be scored on a cost measure, you or your group must have enough qualifying cases to meet or exceed the case minimum requirement for that cost measure. Now, CMS, their intention is to cover every clinician with some sort of cost measure over time. Excuse me. So these are the 5 new measures in specific areas that they felt were necessary for clinicians. And this is psychosis and related conditions, depression, heart failure, low back pain, and emergency medicine measure, which is actually based on location. And this is new and the first measure to be based on location. And CMS has also removed 1 episode-based cost measure, which is the simple pneumonia with hospitalization. Now, CMS has finalized the calculation for the improvement score for the cost performance category at the category level rather than at the individual measure level. And they're only giving a cost improvement score of 1%. And remember, you only need to report on traditional Medicare patients. With these scores in mind, this is what CMS predicts will happen in their crystal ball of numbers and statistics for 2024 final scores. Under the original proposal of establishing the performance threshold at 82 points, they estimated that approximately 46% of MIPS eligible clinicians would receive a negative payment adjustment for the calendar year of 2024 performance, so your payout of 2026. But after receiving an overwhelming public comment negative in favor of continuing that they keep the existing performance threshold at 75 points, they decided to keep it at this for the reporting year of 2024. Because with the PHE, the public health emergency, the removal of bonus points, the requirement to report the cost categories, providers stated that they needed at least 1 year to adjust to all these significant changes. So as you can see, the prediction is now estimated to be at about 22% to receive the negative payment adjustment because the threshold will remain at 75. However, we need to keep in mind that they are still including all the providers that just took the EUC score at 75%, and that doesn't give us a true estimate. So because many providers hadn't reported and automatically took the 75 points, we need to take that into consideration. All right, now we're going to go into the MVPs. And we're going to keep this brief, and I mean brief, but I just wanted to focus on how CMS is going to continue their signal and intent that MVPs are the future of MIPS. Now, MVPs, they did become available this year in 2023, which in theory allows practices to review requirements, update workflows, and prepare their systems as needed to report it once MVPs become required. The MVP framework aims to align and connect measures and activities across the quality, cost, and improvement activities performance categories of MIPS for specific specialties, for different specialties or conditions. And in addition, the MVP framework incorporates a foundation that leverages promoting interoperability measures and has a set of administrative claim-based quality measures that will focus on population health. So while I wouldn't call it a program overhaul or revamp, it's more of a restructuring in the way that MIPS would work. Now, to report an MVP participant would have to register between April 1st and November 30th of the performance year. And you wouldn't be able to submit or make any changes to your MVP that you selected after the close of the registration period, which is November 30th of the performance year. So you won't be allowed to report on any MVP you didn't register for. So you got to think of it like putting your name in the goblet of fire. There are no takebacks. And here you can see the timeline on MVPs and the proposed sunsetting of traditional MIPS. According to the timeline, CMS is getting ready to make 2028 the final year where MVP reporting becomes the first year, where MVP reporting becomes mandatory. So we do have plenty of time to prepare. Now, CMS has finalized 5 new MVPs for the 2024 performance year, along with revisions to the previously finalized MVPs. Specifically, CMS has also consolidated the previously finalized MVP, promoting wellness MVP and optimizing chronic disease management into a single primary care MVP. So this is MVP in a nutshell, and I'm going to hand it over to Lindsay. Lindsay, all yours.
Awesome. Thank you so much, Bridget. All right. If you are in an ACO and you have been exempt from MIPS reporting in the past, you may want to listen up because this is also getting harder. And from our experience, ACOs aren't necessarily shouting it from the rooftops to inform their members. So first is the incentive payment. Historically, if you were in that APM track, you received an awesome 5% lump sum bonus, and you were exempt from reporting on MIPS. A huge incentive, right, in my opinion, to kind of hitch your ride on one of those programs. However, starting in 2023, they wanted to take away any sort of financial incentive altogether. Very rude, in my opinion, but by the power of the people, right? You know, a lot of upset clinicians, essentially, Congress actually did end up reinstating a 3.5% lump sum for 2023, so this year. But they warned there would be no lump sum for 2024 and onward, and they're sticking to it. They did finalize a higher Medicare fee-for-service conversion factor of 0.75% versus the normal 0.25%, but there is no more lump sum incentive. And again, don't forget, you have to qualify to be considered what's called a QP to even benefit from being exempt from MIPS and this new conversion rate. It's not automatic just because you're part of an ACO. And they're changing the logic for determining if you hit that QP status. So they're upping the threshold from 50% to 75% for Medicare payments and from 35% to 50% for Medicare patients seen. And this is all through that ACO or APM. So what I'm telling you is that if you've been considered an APM participant and you've hit your QP status, in previous years, almost every year, starting next year, you may not be in that same boat and you may be required to report on MIPS measures you haven't had to worry about for some time. And that's not all. Initially, in the proposed rule for 2024, CMS was planning to remove the 75% threshold for certified EHR technology cert for advanced APMs, and instead simply having the advanced APM require a total of 100%, right, the use of cert for QP status. Well, after review and consideration, and I imagine a lot of negative feedback, CMS has now decided to delay the implementation of this requirement until the 2025 performance year. So this means in 2025, you must have the required cert in place to become a QP. Now, as we all know, 2023 was a big year of practices having to upgrade systems to be on that 2015 Cures cert, if they, especially were reporting under MIPS. And I know some of our EHR and PM clients stated that they didn't need to upgrade as their ACO met the 75% threshold without them. So that is no longer the case. This is going to be required by January 1st, 2025. So you will need to upgrade in 2024 if you haven't already. And what category requires the use of certified EHR technology under MIPS? PI. So it's no surprise CMS is going to require all MIPS eligible clinicians, QPs and partial QPs that are participating in the Medicare Shared Savings Program ACO, regardless of what track you're on, to report all the measures and requirements under the PI category. You can report at the individual group, virtual group, or APM entity level, and this again will start in 2025. So don't worry, we did just host a PI category deep dive webinar. If you're in this boat and you might need a refresher, it is on our YouTube channel. I do want to point out though, I did say 2025. This was originally proposed for 2024. So CMS is giving you another year to prepare if you're in the Medicare Shared Savings Program. Okay, so with all that in mind, it's clear CMS is turning up the heat, if you will, right, when it comes to reporting under any track of the QPP. But it is December, and I know many of us are focused on, getting through 2023 reporting and maybe not so much 2024 or 2025 yet. So we didn't want to leave you hanging. Here are our top reporting and submission best practices for this year. So let's start with reporting strategies. And I know we're actually doing pretty good on time here. We want to make sure we leave enough time for questions at the end. But we did keep it brief, right? So these are just a few reminders or considerations to keep in mind. First, check your final eligibility. CMS released the final 2023 eligibility to QPP portals and the NPI lookup tool. So take a second and make sure you double check your providers so you are reporting appropriately. You know who's included under your tax ID in CMS's eyes, you know who's eligible and who's not. Next, go ahead and compare your quality versus your PI category performance scores. Again, if you're following our advice or experience to utilize the hardship because you feel like you've been impacted by COVID-19 still, you will be able to pick between those two categories to report on. So determine which category score is higher. If both happen to be perfect, one, great job, but two, consider audit documentation. Typically, quality measures are easier in an audit versus PI because PI has a lot of attestation measures, including the security risk analysis, which is the leading cause of a failed audit. The reason I say you're going to pick between quality versus PI is because we're definitely going to report the improvement activity category, as that is one of the easiest categories to report on because we just need supporting documentation. We don't have to worry about any data or specific threshold or benchmarks. If you do go the quality route, pay attention to truncated or suppressed measures. Bridget already covered what this means earlier in the presentation, and she said CMS already released the MIPS CQMs that are truncated this year. So those are listed on your screen. They, again, have not announced the suppressed measures yet. These are typically ECQMs, and in previous years, they weren't announced really until the last few days of the year, or even after year end, I believe. So if a measure is suppressed and you submit it as part of your top 6, your category score, which is normally out of 60 points, right, 10 points for 6 measures, would actually go down to 50 points. So I know it sounds crazy, but it may actually benefit you to submit a suppressed measure and increase your quality score. On the PI side, or really the improvement activity side too, right, make sure you have your audit documentation saved. This is a reporting strategy, not a submission strategy. I didn't mess up, this is on purpose, because you need to have this saved prior to submission so you know what you can report on. For instance, can you really claim the electronic case reporting exclusion? Why? You will need proof. And once it's submitted, CMS can audit you for it. There's no room for mistakes, there's no going back. And then lastly, check your 2022 cost scores and review your measure guides. You did catch me here. This technically isn't for 2023 performance. Well, I guess if you're using the hardship for cost, but it is for 2024. And that cost tracking begins on January 1st in a few short weeks. So please download the cost guides to better understand what measures apply to your practice, which you can actually see in your 2022 feedback by downloading your CSV file. So even if you weren't scored on cost in 2022, CMS did still provide you feedback on what measures would have applied to you and your potential score for that. You just have to download your CSV file. You won't see it in your overall portal performance or that overview. But download those cost measure guides, review, if it's an episode-based measure, when that pre-trigger point is, when that post-trigger period ends, and understanding maybe what codes are included in that specific measure. Okay, next are our submission strategies. So kind of, last slide was check your QPP eligibility. This one is check your QPP credentials. Make sure you don't have to reset your password, or you're locked out, or you aren't connected to your practice, or maybe you have the wrong role. You're not a security official. I joke with my clients all the time that this is usually the hardest part each year. And you will need to sign in here to submit your COVID-19 hardship if you're moving forward with that. If you do move forward with that hardship, we recommend that you would submit it for all categories, and then you would override it for improvement activities and then either PI or quality. Again, that would keep you safe from cost and truly try and maximize your score. But please understand you will need to describe how COVID-19 is impacting your practice on this application. If you are choosing to report PI and IA and you're a small practice, so remember, small practice equals under 15 clinicians in CMS's eyes, you will need to log in and check the QPP to make sure CMS doesn't have any claims data for you in the quality category. We saw some practices actually burned by this in previous years. To be clear, not our practices, because we knew about this, but ones who are new and coming to us for help now. They went ahead and submitted their PI and IA data with their hardship, but then they got a score on quality and they didn't understand why. And that's because the practice had claims data showing in their quality category. Because if you're a small practice, you're allowed to submit quality data via claims using those old codes from PQRS. Now, I would say 99% of practices don't do this anymore, but it only takes one code to still be lingering on your claims that will signal quality reporting to CMS, which can honestly ruin your reporting plan. If you do log in and you do see you have claims data, you're going to have to report quality and improvement activities versus PI and IA. And then finally, when you do submit, make sure to export your patient detail reports that same day so your numbers match what you submitted and what you have downloaded, and save that in your audit binder. In fact, save everything to your audit binder. CMS is hitting audits hard in 2022 and 2023, or for 2022 and 2023, I should say. And I would make sure you have everything you need, because we just went through them with clients this year. It's much more of a pass-fail experience than in the old meaningful use days when you kind of had a conversation with your auditor. Maybe, they told you what was missing and you could resubmit something. That is definitely no longer the case. So again, that was a lot. I hope no one's feeling overwhelmed or worried. We just want you to earn a high score and be in the know and understand that we're here to help. So I mentioned, you can visit us at our website to learn more about us, maybe if you're new to DAS. Make sure to continue to sign up for our webinars. Our historical webinars are actually housed on our YouTube channel. You can view those here. And then, of course, follow us on LinkedIn. We post news and updates, but we also post our future webinar announcements with a link to register on there as well. If you are considering working with our government incentives team, we do offer guidance and assistance really in any form you need it. You'd be working directly with myself, Kimmy, or Bridget. Just reach out to your DAS account manager if you have one, or if you don't, you can email me directly. My contact information is on the screen. But enough talking. We'll go ahead and open the floor up to questions as we promised. So please remember, you can put any question you have in the questions box on the webinar control panel, and we will do our best to answer them live. I'm going to probably ask Bridget for your help in fielding some of those questions if they're coming in, if you have access to them.
Yes, I do. And I also want to apologize for my voice. I've been under the weather, as Lindsay knows, and I was going to get through this webinar. So I apologize for my part of the presentation where I almost lost my voice about 3 times.
No, you did great. You did great. I didn't hear a single cough.
Yeah. So we have a couple that came through, actually from Tina, and she has some good ones. Can a hardship request be denied?
So typically how it works, the hardship that we're recommending clients to submit is the hardship related to COVID-19. It's this extreme and uncontrollable hardship. Now, I will be very upfront. You will have to put a reasoning in there stating how COVID-19 is impacting your practice. But hardships for that reason right now are actually on automatic approval. Keep in mind, the public health emergency was still active this year. It did end back in May, but we did still have, part of the year in that PHE status. So I believe that's why CMS actually has hardships for that specific reason on automatic approval. If you use a different reason, or if you pick the PI hardship, not the extreme and uncontrollable hardship, those tend to go into a pending status, and CMS will then review those, and then you'll hear back if it was approved or denied. So yes, they can get denied, but just note the specific EUC or extreme and uncontrollable hardship we're referring to today is actually on automatic approval, as long as you can justify how COVID-19 is impacting your practice.
Perfect, thank you. And she also has another question. It's basically referring to audit, like audit binders, or what assistance or recommendations do we assist with for auditing?
Great question. I can jump in again, but Kimmy and Bridget, keep me honest too if you have anything to add. We recommend whatever feels comfortable to you. I'll be honest, we typically recommend an electronic audit binder. I know we used to recommend having the actual physical binder in the office. There's no harm in having both. You have to keep in mind, if you have an electronic copy of your audit binder, that needs to be backed up and saved somewhere. So if something got deleted, it wouldn't be gone forever, right? Because CMS can audit all the way back to 6 years. So we would assist with our ongoing clients, or even our hourly clients that we help with. We will go ahead and export your final reports if we're helping you with submission. We'll export your patient detail reports. Make sure you have those tucked away, and then we'll provide guidance and of course help review documentation if you have it for your improvement activities. We'll take an activity, look at the validation criteria from CMS, and advise you on what we recommend you save down. You can show that to us, and we'll review it with you and give you some pointers or feedback on that. Same thing, we'll make sure that you're aware of all that's required for documentation-wise, especially in the PI category. We'll try and give you some examples for electronic case reporting. Maybe you're trying to take the exclusion. We'll assist with reaching out to your state and trying to, make sure we have an email from your state saying we're not accepting data on those conditions, or we'll get the list of reportable conditions for you and we'll review it with you, and then we'll help you, type up a letter on your letterhead, or create, we have some clients who've created a script to run all those diagnoses to make sure that none of those were used to claim that exclusion. So a ton of different ways to keep that documentation. We absolutely assist with guidance. And then, of course, if it's related at all to your reports or anything in your EHR that we're assisting with, we will absolutely save that down and send it for you to save in your own binder.
Awesome. Now, Lindsay, we do have a couple more, but I know we're right at the top of the hour. Do you want to just personally reach out, or you want to take? Okay, perfect.
No, we'll go ahead and take them.
Okay, the next one we have is, I think this is important, if they have taken the EUC each year, and now what do they have to do to earn on cost so that it's included next year and they won't be penalized? So like what do they have to do to not be penalized for cost? I
can take that one. And then I'm going to give you guys the questions. So keep in mind, this was where the big win was for the threshold staying at 75 versus increasing to 82. So cost is worth 30% of your score. So literally 30 points out of your 100-point MIPS score. So with the threshold being at 75 points to avoid a penalty, technically, as long as you can get 100% in quality, PI, and IA, or if you're a small practice, quality and IA, you really only have to earn 5 points in the cost category to avoid a penalty. Whereas when it was proposed, we would have had to earn at least 12 points in the cost category. And that is a big difference. So that threshold staying at 75 was a huge win. Again, we recommend absolutely going into your QPP account and downloading your 2022 feedback so you know what measures are applying to your practice, and then you can access CMS's measure information guides on each of the measures that are applicable to your practice and begin to understand what CMS is tracking and looking at and scoring you on.
Thank you. Okay, either one of you guys, I do have one more. If we submitted the EUC for 2023, do we still have to register for the ECR? Kimmy, I don't know if you want to take this. Okay, perfect.
I can answer that one. So if you have the EUC already, since the ECR is under the promoting interoperability category, if you've filed with the EUC and you have reweighted all 4 categories, you don't still have to register for that one. You can just leave it until next year.
Perfect.
Yep, and just keep in mind, if you're trying to report, right, if you're trying to consider reporting PI over your EUC, I think that's, Kimmy, what you were getting at, right? That's the only time, right, that we recommend that you register. I mean, if you wanted to register now, it might help you in the future for next year to prepare yourself one less thing off your list. But Kimmy's dead on that you wouldn't need it if you're really trying to take the EUC and not report it all this year.
Awesome. Okay, I think that looks like it. If I'm missing any, I don't see. I think we're pretty good. Thank you, everyone.
Awesome. Okay, everyone, thank you so much for joining today and taking time out of your day to sit and chat with us about MIPS. Please don't hesitate to reach out if you have any questions or concerns or you're interested in working with our awesome team here. So thank you all so much.
Thank you. Bye.